You went for a routine ultrasound, and the report drops that one word, nodule. Your doctor says, "We'll keep an eye on it," but your brain only hears one thing, cancer. Before you spiral, hit pause. After 40, thyroid nodules are incredibly common, and most are not cancer. In this video, I'm going to walk you through the 3-step safety system doctors use to sort out the scary from the harmless. First, the ultrasound risk score, TI-RADS. Then, if needed, a tiny needle biopsy. And finally, the Bethesda result that tells you what happens next. By the end, when you see the word nodule on a report, you'll know whether it's time to worry or just time to watch it calmly. Now, let me guess how this actually went for you. You didn't go in because you felt a lump. You went for something routine, maybe a carotid ultrasound, maybe a check on your thyroid because of fatigue, maybe an annual exam where your doctor casually said, "Let's just make sure everything looks okay." The scan took 10 minutes. The tech was polite but quiet. A couple of days later, the report pops into your portal, and there it is. Thyroid nodule identified. One word, no explanation. Your doctor messages, "Very common, we'll just watch it." But your brain doesn't hear common. Your brain hears, "Is this cancer?" You start Googling. Bad idea. In 2 minutes, you've gone from tiny nodule to worst-case scenario, planning a future surgery you haven't been offered, imagining a diagnosis you do not have. Let's slow this way down. Here's my opinion, and it's the backbone of this entire video. A thyroid nodule is a finding, not a verdict. After 40, most nodules are benign, and modern thyroid care is built to filter out the dangerous few without dragging everyone else into panic and unnecessary surgery. But almost nobody explains that system to you. So today, I want to hand you the map, because there is a map. Doctors don't just look at your ultrasound and guess whether it's cancer. They usually work through a 3-step safety pipeline. 1. Ultrasound risk score, often called TI-RADS. 2. Biopsy if needed, a fine needle aspiration, FNA. 3. Bethesda category, the pathologist report that guides the next move. If you understand those 3 steps, your entire relationship with the word nodule changes. Before we go into the pipeline, I want to zoom out and give you some context your anxious brain probably skipped right over. Thyroid nodules are extremely common, especially after age 40. Autopsy and ultrasound studies show that a large share of adults, many people walking around feeling fine, have nodules that were never even noticed. The majority are benign and never cause trouble. And even when a nodule does turn out to be cancer, the most common type, papillary thyroid cancer, usually has an excellent prognosis when it's found early and managed appropriately. None of that means you shouldn't take your health seriously. It just means the presence of a nodule is not a death sentence. It's a clue, and clues are meant to be interpreted, not feared blindly. Here's the problem I have with how this often plays out. The system is designed to be careful and risk-based, but the communication is often lazy and vague. You get, "We'll follow it," with no explanation of why they're not rushing to biopsy. Or you get, "We need to biopsy," with no clear explanation of what exactly about the nodule triggered that decision. So your mind fills in the silence with the worst story it can find. Let's change that. I want you to think of every thyroid nodule like a passenger at airport security. Step 1. The ultrasound is the metal detector and scanner. It doesn't say guilty or innocent. It says low suspicion, intermediate, or high suspicion. That's TI-RADS. Step 2. Only if something looks concerning enough does the person get pulled aside. That's your needle biopsy. Step 3. Then security opens the bag and actually looks at what's inside. That's the Bethesda result, where a pathologist examines the cells and assigns a risk category. Seen that way, you start to realize something important. Not every nodule should be treated like a bomb. Some are more like a random metal button on your jacket that sets off the detector. It still gets checked, but no one shuts the whole airport down over it. Now, I want to pull you into this in a personal way with the first reflective question. When you saw or heard the word nodule, did you immediately jump to the worst possible story without ever asking what kind of nodule, what risk level, or what your ultrasound actually showed? Because that jump, that mental freefall from nodule to cancer, is where a lot of unnecessary suffering lives. In this video, we're not going to pretend nodules never matter. Some absolutely do. Surgery saves lives in the right situations. But my stance is this. If you're over 40 with a thyroid nodule, your real job is not to decide, panic, or ignore. Your real job is to understand the system well enough that you can ask the right questions and avoid both overreaction and neglect. So here's how the rest of this episode will unfold. We'll start with step 1, TI-RADS, the ultrasound scoring system. I'll translate the strange words like hypoechoic, microcalcifications, and irregular margins into plain English and explain why some nodules are boring and some earn more attention. Then we'll move into step 2, when a needle biopsy actually makes sense, and why size plus pattern, not just the word nodule, drives that choice. Finally, we'll break down step 3, the Bethesda categories, the 6 labels that come back on biopsy and what they actually mean for your next move. By the end, I want you to be able to look at your report and say calmly, I know my TI-RADS score. I know whether I meet biopsy criteria. If I get biopsied, I'll know how to interpret Bethesda 1, 2, 3, 4, 5, or 6, and what question to ask next. Let's talk about that strange code that shows up on your ultrasound report. You see phrases like solid hypoechoic nodule, TI-RADS 3, or TI-RADS 4, recommend biopsy if greater than or equal to 1.5 centimeters. You're thinking, I don't speak robot, is this good or bad? Here's the big secret. TI-RADS is just a risk score. It's not a diagnosis. Think of it as your nodule's report card, not on how nice it is, but on how suspicious it looks. Radiologists give your nodule points based on a few features. Composition. Is it mostly fluid, mostly solid, or mixed? Fluid-filled cystic nodules are usually boring and low risk. Echogenicity or brightness. Is it brighter, the same, or darker than the normal thyroid tissue around it? Darker, hypoechoic nodules get more attention. Shape. Is it wider than tall, like a pancake, or taller than wide, like a tower? Taller than wide earns more suspicion. Margins. Are the edges smooth and well-defined, or irregular and spiky looking? Little spots inside. Tiny calcium specks called microcalcifications can bump up the concern. Each of these things adds or subtracts to your total TI-RADS score. Then the nodule gets a grade, usually from TR1, very low risk, to TR5, highly suspicious. Here's where people get tripped up. They see TR3 and think, oh no, level 3 out of 5, that must be awful. But in reality, TR3 is still low risk. It basically means we see a nodule, it has some features, it doesn't look super scary. And then there's the crucial part, size. TI-RADS doesn't just say, this looks a little suspicious, so let's stab it. It says, this is how suspicious it looks, and here's the size at which a biopsy makes sense. For example, a TR3 nodule, low risk,
might only be considered for biopsy if it's around 2.5 centimeters or larger. Smaller than that, often just follow-up ultrasound. A TR4 nodule, moderate suspicion, might be biopsied at a smaller size. A TR5 nodule, high suspicion, might deserve a biopsy even when it's relatively small. In other words, your nodule is judged by both personality and size. This is where my opinion may sound a little strong, but I mean it. The single most important question most people never ask is not, do I have a nodule, but what is my TI-RADS score, and does it actually meet biopsy criteria for its size? Because if your report says TI-RADS 3, 1.2 centimeters, that's a very different story from TI-RADS 5, 2.4 centimeters. Let me give you a human example. Two friends, both 52. Friend A has a 1.1 centimeter TR3 nodule. Low risk pattern, smooth edges, mostly solid, not particularly dark. Her doctor says, we'll recheck in a year. She goes home and panics because nothing was done. Friend B has a 2.1 centimeter TR4 nodule. Darker, a little irregular, maybe some tiny calcifications. Her doctor recommends a biopsy.
She panics because something is being done. The irony? Friend A is likely safer than she feels. Friend B is likely safer than she fears, because the whole point of finding a higher risk nodule is to check it early, not to wait until it's too late. TI-RADS exists so we don't biopsy every harmless little bump and don't ignore the few that actually need attention. Now I want to pull you into this more directly. Second reflective question. When you heard you had a nodule, did you stop at the word nodule, or did you ask for the actual TI-RADS score and biopsy cutoff for your nodule size? If no one told you that, you weren't given the whole story. And this is what bothers me. We've built a fairly sophisticated system to avoid unnecessary biopsies and surgeries, but the people whose necks we're scanning are left out of the conversation. So let's fix that right now. Here's a mini script you can use with your doctor or radiologist. What is my TI-RADS category? At what size would this category typically need a biopsy? Is my nodule currently above or below that threshold? If we're just watching, what's the plan? How often and what changes would trigger a different decision? If your nodule is below the biopsy threshold and low to moderate risk, watchful waiting isn't your doctor being lazy. It's the system doing exactly what it was designed to do, protect you without turning every harmless bump into a surgical case. In the next part, we're going to cross that threshold and talk about what happens if your nodule does meet the criteria for a closer look. The fine needle aspiration biopsy, what it actually feels like, and why not every suspicious-looking nodule automatically means surgery. So, let's say your nodule does cross that line. Maybe it's a TR4 at 1.8 centimeters. Maybe it's TR3, but big enough that guidelines suggest taking a closer look. Your doctor says, we're going to do a fine needle aspiration. And the words you hear are needle and thyroid in the same sentence. Let's demystify that. A fine needle aspiration, FNA, is basically a tiny sample. Most people are sitting up, a little reclined. The skin on your neck gets cleaned, you may get a little numbing medicine, and under ultrasound guidance, a very thin needle goes into the nodule to pull out some cells. It's usually a few quick passes. Not fun, but typically fast. No, they're not cutting your neck open. No, they're not taking out half your thyroid on the spot. This is more like a sip of cells than a chunk of tissue. And this is important. We only want to do this when the result will actually change what happens next. That's why TI-RADS and size matter so much. A borderline-looking, tiny nodule often doesn't get biopsied because even if it were something, the plan would still be to watch.
A larger or higher risk nodule gets sampled because the result could change everything: watch, operate, or something in between. Now, what happens to those cells? They go to a pathologist, the person whose entire job is to stare at cells on a slide and say, "This looks benign, this is suspicious, or this is clearly malignant." To keep the language consistent, they use a 6-level system called Bethesda. You don't need to memorize every word. You just need the translation. Here's the simple version. Bethesda I, non-diagnostic. Not enough cells, or the sample wasn't clear. It's like a blurry photo. Often, the plan is to repeat the FNA or keep a close eye with ultrasound, depending on how suspicious the nodule looked to begin with. Bethesda II, benign. This is the one everybody wants. It means the cells look like normal benign thyroid tissue. The risk of cancer here is very low. The usual plan? Surveillance. Periodic ultrasound to make sure the nodule isn't growing aggressively or changing its personality. Bethesda III and IV, the gray zone. This is where the anxiety meter usually spikes. 3 often means atypia of undetermined significance. Something looks a little off, but not clearly cancer. 4 often means follicular neoplasm or suspicious for follicular neoplasm. Again, a pattern that could be malignant, but often isn't. These are not "you have cancer." They are "we're not sure yet." Options here might include repeating the biopsy, doing specialized molecular testing on the cells, or considering surgery if the overall risk feels high enough. Bethesda V, suspicious for malignancy. Now, the pathologist is leaning hard toward cancer, but the sample doesn't quite check every box. Many of these nodules turn out malignant on final surgery, so surgery is often recommended. Bethesda VI, malignant. Here, the cells have a clear cancer pattern. Most commonly, this is papillary thyroid cancer, which, in many cases, has an excellent prognosis when treated appropriately. Now, here's the part almost no one tells patients clearly. A lot of biopsies come back Bethesda II, benign. A meaningful chunk fall into 3 and 4, the gray zone. And most of those gray zone cases still end up benign in the long run. So why all the stress? Because we're human and we hate uncertainty. But in thyroid land, indeterminate does not mean doomed. It means we need more information, and we need to weigh the whole picture: your age, nodule size, ultrasound pattern, family history, and your own tolerance for risk. This is where I see so many people over 40 get dragged into either extreme. They hear indeterminate and think, "Just take it out, I want this thing gone," without realizing surgery isn't a zero-risk decision. It can mean lifelong thyroid medication and a scar for something that might never have hurt them. Or they hear, "Let's repeat the FNA in 6 months," and feel like the medical system is gambling with their life, when in reality, the goal is often to avoid cutting out perfectly harmless thyroid tissue. Here's my stance. The real power move is not demanding action at all costs. It's understanding the odds well enough that you can choose between watch, test more, or operate without feeling railroaded. So let's pull this back to you for a second. Third reflective question. Have you ever treated medical uncertainty, words like indeterminate, low risk, or let's repeat this, as if they automatically meant disaster, instead of seeing them as a signal to slow down and gather more information? Because the temptation, especially after 40, when you've seen people you love get scary diagnoses, is to assume that anything less than 100% guarantee equals catastrophe. But here's the truth. In thyroid nodule world, certainty often comes with a cost, and sometimes that cost is a surgery you might not have needed. So, in summary, this pipeline you're in is not random. TI-RADS plus size decides if your nodule gets a needle. FNA collects cells so Bethesda can decide how risky those cells look. Bethesda then frames the next step: watchful waiting, repeat testing, or considering surgery. In the last part of this episode, we're going to take everything you've just learned and turn it into a simple, practical anti-panic playbook you can literally write down and bring to your next appointment. Let's pull this all together, because at the end of the day, you don't want to be a part-time thyroid expert. You just want to know, I'm safe, and what happens next. Here's the truth I want you to remember long after this video ends. A nodule is a flag, not a verdict. The whole TI-RADS, FNA, Bethesda pipeline exists to answer one question. Is this something we can safely watch or something we need to act on? But if you don't know how to work with that system, it can feel like you're stuck in limbo, half worried, half in the dark. So let's turn everything we've talked about into a simple anti-panic playbook you can actually use. Step 1. At the ultrasound stage. When you get your ultrasound report, or you're back in the office reviewing it, your job is not to obsess over the word nodule. Your job is to ask, 1. What is my TI-RADS category? TR1-2 equals very low risk. TR3 equals low risk. TR4-5 equals rising suspicion depending on features. 2. How big is the nodule? Exactly. Size in centimeters matters just as much as the pattern. 3. For this TI-RADS score, at what size would you normally recommend a biopsy? This connects your report to real-world decisions. 4. Does my nodule meet that biopsy criteria today? If no, then watchful waiting with repeat ultrasound is not a brush-off. It's the guideline-based plan. If yes, then FNA is about clarity, not punishment. If your nodule is below the biopsy threshold and low risk, your action step is not panic. It's, okay, this is a low-risk nodule. We're watching it.
What's our follow-up interval? 6 months? 12 months? Step 2. If you have a biopsy, FNA. If you cross that threshold and your nodule gets a needle, your mindset shifts from do we test to how do we interpret the test. After the FNA, here are the questions you bring back to your doctor. What Bethesda category did my biopsy come back as? What is the approximate risk of cancer with that category? Given my age, ultrasound pattern, and this Bethesda result, what are the reasonable options? Quick mental translations. Bethesda II, benign, surveillance. Bethesda III and IV, gray zone. Repeat FNA, molecular testing, or surgery may be on the table, but many of these end up benign. Bethesda V and VI, likely or definite malignancy. Surgery is usually recommended, but the prognosis, especially for common types like papillary, is often very good when treated properly. This is where understanding the system keeps you from swinging between do nothing and take it all out now. Step 3. If it's benign or low risk. Here's the part most people forget. Even good news needs a plan. If your nodule is low risk on ultrasound or Bethesda II benign, ask, how often do you want to recheck with ultrasound? What kind of change, in size or appearance, would make you rethink our plan? Are there symptoms I should watch for that would trigger an earlier visit? This turns a vague, we'll keep an eye on it, into a specific, calm follow-up schedule. Because that's the real goal here, a plan you can live with without mentally checking your neck every 10 minutes. And I want to ask you something straight. If you had a clear, written plan, your TI-RADS score, whether you meet biopsy criteria, your Bethesda result, if biopsied, and the agreed follow-up schedule, how much anxiety would that take off your shoulders compared to just holding the word nodule in your head with no context? My bet? A lot. Because most of the fear around thyroid nodules doesn't come from the nodule itself. It comes from silence and ambiguity. So let's end that right now with one more crucial piece. I am not a doctor. This video is for educational purposes only and is not medical advice. Do not use this video to diagnose yourself
or to start, stop, or change any treatment. Always talk to your physician or a qualified healthcare provider about your specific case, your test results, and your options. Use what you've learned here as a conversation starter, not a replacement for care. Here's your take-home checklist. You can literally pause and screenshot. 1. Ask for your TI-RADS score and nodule size. 2. Ask if your nodule meets biopsy criteria today. 3. If you've had a biopsy, ask for your Bethesda category and what that means in terms of risk. 4. Agree on a next step that matches that risk. Watch with repeat ultrasound. Repeat FNA or consider molecular testing. Talk to a surgeon if risk is clearly higher. 5. Lock in a follow-up plan so you're not living in wait and worry mode. And remember this one sentence if nothing else sticks. A thyroid nodule is a finding, not a fate. You are not your ultrasound report. You are not a single word in a portal. As we wrap up, I want to invite you to zoom out even further. Nodules, TSH, antibodies, they're all pieces of the same thyroid story: metabolism, energy, and long-term health after 40. If this episode helped you feel calmer about nodules, the next step is to understand how the rest of your thyroid picture fits together, from subclinicalhypothyroidism to autoimmune flares to medication decisions. I've put these videos together like a little thyroid season playlist, so you're not just reacting to one lab at a time, but actually seeing the whole map. Before you click away, take 1 minute to write down, on your phone or a sticky note, the one question you'll ask at your next appointment about your nodule: TI-RADS, size, biopsy criteria, Bethesda result, follow-up plan. Pick one, because the shift from fear to ownership starts with a single, clear question asked by you.